Hello everyone, thanks for joining us in this webinar Supercharge Your Aligner Results with Dr. Ivan Malagon. This is Santiago Lombardia, Territory Manager of OrthoAxel in Spain and Portugal. We are many doctors connected from all over the world. It has been a great success to have you all here interested in seeing Dr. Ivan Malagon about his experience combining Accelerant and Invisalign. Let me introduce Dr. Ivan Malagon. He was graduated in dentistry from Universidad Complutense de Madrid, and he got his specialty in orthodontics in University of Southern Mississippi Institution, also here in Madrid, as there is a dental school of this university here in Madrid. Dr. Malagon has treated more than 1,800 Invisalign cases. He is Advantage Elite Club member and the only doctor in Spain who has reached the Diamond category in Invisalign in all its editions. He is key opinion leader of Align Technologies as well. He is director of the title University Expert in Aligner Orthodontics from Universidad Alfonso X el Sabio in Madrid. He collaborates with the postgraduates program in Ortho of Universidad Alcalá, and he is also co-director of the Clear Ortho International program. Before giving him the word, let me quickly remind you a couple things about the webinar. All the attendees are muted, so if any of you want to ask a question, please do it by clicking the button at the bottom left part of your screen, and after his presentation, Dr. Malagon will answer as many questions as he can. If we run out of time and we don't have time to answer them all, we will get in touch with you to give you an answer. So please, Dr. Malagon, whenever you are ready, we are ready.
Good morning, everyone. Dear doctors, thank you all for your time. I'm very proud of the great success of this event. It's an honor for me to feel that I'm useful for you. I do everything in my power as always to meet your expectations. My name is Ivan Malagon. I come from Madrid, Spain. If you haven't been before here, I recommend you to come because it's a city full of light and energy, and people are very open-minded. I love that Madrid never sleeps. This is my clinic. I am an exclusive orthodontist, but I have a team of professionals who cover the rest of the dental specialties that help me achieve good results in the patients who decide to put on my hands their dental health. And well, here you have, this is another part of the clinic. It's a modern clinic. I feel that my patients have to feel very comfortable there, and everything has to be coherent, because it's not only it's not only the image, the smell, or the treat they receive. So it's everything, the technology they see all over. Another part of the clinic with part of my team. And here you have that this small device of plastic and rubber, apparently simple, but that gives us an added value when it apparently comes to get a better reaction of the tissues that support the teeth during orthodontic movements. In my opinion, dentistry of the 21st century must be synergized with the latest technology, and everything that provokes a better response to the stimulation applied with any kind of orthodontic system, we must control it perfectly as well as offer it for the benefit of our patients. So I think this is a very good idea for today. I'm gonna speak about some benefits of soft pull forces in ortho treatments. The first one, less painful movements. The discomfort suffered by orthodontic post-activation patients is due to the traction exerted by the periodontal ligaments on a very thin and very inelastic membrane, which is called periosteum. When we stimulate these ligaments with vibrations of a certain magnitude, we dilate less that membrane, and consequently we cause less pain. In terms of patient's commitment, the connection between doctor and patient has changed a lot in recent years. Years ago, the doctor could be unfriendly or not give all the information he knew to the patient because it was what happened commonly. But nowadays, it's absolutely necessary that our patients feel that their dentist is in control of their treatment in almost daily follow-up, and the interactivity offered by applications such as Accelerant ones makes it easier for each patient to feel special, because although we have many patients every day, we are the only dentist for each of them. We need to take care of it. Talking about better fitting of aligners, when my patients change to a new aligner, I usually recommend that they have to bite the chewing for at least 1 hour to ensure the adaptation of the aligners and that they transmit adequate strength in the first 2 hours at least, which is when the phenomenon of apposition, bone resorption, and tooth movement occurs. If in addition the patients use Accelerant for 20 minutes a day, especially after 8 p.m., is when I mostly recommend it, and it's when cellular activity is increased, the vibration causes a better fitting of aligners throughout the treatment with a consequent increase in the predictability of the movement. In terms of speed up, bone remodeling, in the last 3 years I've seen clearly how the stimulation that Accelerant causes makes the virtual space occupied by the periodontal ligament look less thickened. And the thickness of the periodontal ligament during orthodontic tractions is a clear sign that we are providing adequate strength during the treatment to achieve a better and faster bone remodeling by stimulation of cellular activity. Promote blood and plasma supply. Well, it's scientifically proven that Accelerant improves the blood and plasma supply so that the tissues surrounding the tooth are increased in the amount of nutrients and mediators of the inflammatory response. Help periodontal soft tissues recovery. Well, the visual consequence of all of this is that the architecture and the consistency of the soft tissues improves if I use Accelerant. I'm looking at this every day in my clinic. Less treatment time. Well, you see that it's by last, and for me, it's the least important thing of all. Is that as a consequence of all the above, of course, the treatment time decreases between 30 and 40%. So less time is more money. Time is money. We agree. We all agree about that. I'm going to start with a few cases. I will try to show some important points for you to understand why I have incorporated that devices to my daily routines in my clinic. The first case is a case of deep bite with the canine. If you see the canine here, this is the cusp, and this is a veneer, composite veneer, and that was the main concern of the patient. The second case is an open bite. You see that is, of course, open bite with a tendency across bite and very constricted arch, especially the upper one. That's why the canine is there up to the occlusal line, and the lateral is important cross bite. The third one is an interdisciplinary case in which we will try to get good proportions, good image of gums, good alignment, of course, to get that leveling, and of course a wider and beautiful smile at the end of the treatment, taking into account that that crown is a canine because it was agenesia of both lateral definitive incisors, lateral incisors. So this one is a temporary one, and this one is a canine with a very bad crown. You can see here the unleveled gums. This one is a canine, but it's a temporary canine, so I will try to get good proportions using aligners, putting that root of that canine into the bone and getting a better support for the gums using accelerant, of course. That for me is mandatory in that kind of cases. Number 4 is a case of distalization. You see it's a class 2, it's an important class 2 with retrocline incisors, very bad engagement in the posterior side, and here, of course, in the front. We will have to fix it properly. The next one is a complete class 2. It's a very big class 2 with 13 millimeters overjet by maxillary cost. So it's a challenge for us to treat it, and we are used to do that with aligners and elastics, of course, and distalization if we need upper distalization. But of course, to remodulate the bone and to remodulate the TMJ, to use other appliances like that devices of who gives us appropriate soft pulse forces. The last one is a case of crossbite, severe crowding, very constricted, a canting of the plane is evident, and of course, to maintain that system alive for life, we have to do something. It's clear for all of us. Let me remind you that to achieve excellent result, the only important thing is not accelerant, of course, it's obvious. So that it's mandatory that the diagnosis of the problem is correct, the treatment planning is appropriate, and the patient's collaboration is up to par, of course. If these requirements are met, accelerant is another tool that will help us to get a better response of the tissues as well as its consolidation. Unfortunately, it's frequent that the objective of some doctors are not precisely the most suitable for the patient, either because their training was not enough, or because they have no experience, or simply because they don't want to get their lives more complicated, maybe. In these cases, accelerant is even more necessary because at least it greatly improves the predictability. Let's start with that cases I've been talking about before. That girl came to my office asking for that canine to cross that bite of that canine that was covered by a composite veneer. But of course, when we open the mouth of the patient, we see that it's a big overbite. The gums are completely underleveled. You see the reactions of the gums to that overloaded system. The unleveled from lateral to central, the biggest step here between the edges, and that kind of, it's a veneer, composite veneer, that of course is not beautiful, but what is worse, the function is not correct in that kind of patient. So we have to fix it, not only to improve the alignment, so we have to improve the way the teeth are biting against the antagonist to get a better function, not only in centric movements, but it's very important in eccentric movements, in lateral and progressive guides. Here we can see the clean check after a lot of modifications, because I am very perfectionist, so we can see how we can expand. We have to control the torques of motors to maintain the torque using that big blocks of gingival papal attachments, 5 millimeters long, horizontal rectangular in first motors. It's very important to use that kind of attachments to control the root tipping of central incisors, because the tipping of incisors, upper and lower, have to be completely parallel if we want not to overload the soft tissues during the life of the patient, because the progressive guide will damage that soft tissues if the torques of the upper incisors and the lower incisors is not correct. We see how we are jumping that bite only with aligners. In 19 aligners, it takes around 5 months treatment, because I'm changing aligners every week. So 5 months treatment, we have to get that situation. We see the initial picture with that overbite, that unleveled gum, and that crossbite in the canine. This is after the ortho treatment, and look, you can compare the difference between the initial picture and the last picture. You can compare the leveling. Of course, we have intruded the central incisors, we have leveled the lateral incisors, we have intruded lower incisors as well to get a good curve of SPE, because it's absolutely necessary to get it absolutely flat to improve the biting. Here you can see the canine, and here you can see the veneer. We have got good proportions, good parallelism between roots, and we have got a very good overjet and overbite. Here, it's in that kind of patients in which I have to improve the soft tissues because are very damaged. As you can see here, even the gums on canines are much better at the end of the treatment after only 5-6 months treatment. And of course, the treatment plan is very good, but it's absolutely necessary to use devices as accelerant to expect a better response of the soft tissues. You can see here the clean check in the front view, the amount of expansion I got, the round tripping of that incisor of that canine, to get the good predictability in the tipping of the root. We must start with the distal backup rotation. Then we start moving. In the moment we have completely aligned from canine to canine, we start moving from mesial to lingual, taking advantage of the second phase of the round tripping. And if we have to do an IPR, that usually a stripping has to be done, it has to be in the moment we have enough access, so that after the first phase of round tripping, that we get access enough to do that without devastating too much enamel, and we take advantage of that second phase of round tripping to get that parallelism between roots. The tipping is necessary to get. In that view, in which you can see that canine cusp with that veneer and that big step between incisors and canines, you see after the ortho treatment with the restoration of the edges, of course, you see here how the canine is perfectly positioned. You can compare it easily. Midline centering, good response of soft tissues. Seems like the health of them is very good. In that side, in the right side, you see how the tipping of the canine is not correct. Of course, we don't have any canine guide here because the cross-bite of the canine is not allowing us to do that. So we have to start jumping that bite, of course, change the tipping of canines, incisors, the proclination of incisors to get space enough for protrusion and intrusion lower incisors. You see after ortho treatment how the canine is there, positioned in a good class 1, and the tipping is very good as well. On the other side, similar. We have got good projection of the roots here in the lower incisors, and the leveling of the gums is very good. That arch shape is not correct. You can see here the canine with the veneer, and we don't have good contact points between canine to canine. At the end of the treatment, we get that wider arch. We get that wider arch. You can compare from this to this. It's wider, it's a better smile, and of course we have a good torques from canine to canine that is absolutely necessary to maintain the durability of the system, periodontal system. The lower arch, you see that is a square arch. That canine is suffering a lack of space. Here, at the end of the treatment, we get very good contact points. We have to be very perfectionist with the torques and apply exactly the same information in all the teeth to get at the end good progressive guides and good canine guides. This is the X-ray, initial X-ray, and at the end of the treatment, you see that the curve of space leveled, and the leveling of the bone is good enough to understand that it's working very good, and that's why the soft tissues are recovering. This is the lateral X-ray at the beginning, and at the end, you see how the incisors are correctly positioned in their bases. And of course, if we get that symmetry, you see at the beginning how it's much more constricted that side of the face because of the crossbite. Usually, some patients try to bite only that in one side and have much more constriction in one side than the other, but when we jump that bite and we get good proportions and the biting is correct and the mandible is unlocked, we find how even the nose, not only the lips that of course is much better at the end, even the nose seems to be more centered, and of course we haven't done anything in the mouth, in the nose. The smile is very proportional, wider, and for sure the patient is very happy. And here you have a small picture about how the pressure have to remodulate, have to resorb the bone here in that area, and have to try to expect the bone deposition in the other side. That's why we move the teeth where we want, of course. And the forces that acceleratants apply are calibrated to transmit that force to the roots and to help the remodulation of the bone. It increases the cellular activity and speeds the rate in which your teeth can move. So it's better for the patients and better for us, of course. Another case, the patient was living far away from Madrid in Italy, and he told me, well, Ivan, for me time is very important because I'm studying far away from here, but I want you to treat me. I cannot come more than 3 times a year, so give me options for me to try to do a treatment, because if not, I will not be able to do that ever. So we find midline deviation. Of course, the upper midline is deviated to the right because it's filling the space of that lateral as well as the canine that is rotating and up to the line of the occlusal line. We see how the unleveled tissues are, it's a very young man. So imagine after 20 years, that gums will be much worse. So we need to level that gums, getting a better function of the teeth. And for that, in that kind of cases in which I need to have very good control of the movement, very good fitting of the aligners, and the good response of the soft tissues, I need acceleratant. If my patient don't uses the acceleratant, for sure we will not get the same results in terms of consolidation of movement, in terms of remodulation of the soft tissues, and that architecture that we are looking forward always. So here you have the clinic to do that huge movement. I have to do round tripping, of course, because there's no other way. The way is extract teeth, and I don't want to extract teeth if I can do that kind of treatments. And today I have less than 1% of extraction cases, because now we can stimulate, we can remodulate, we can create bone. So if we create bone, if we create wider arches, there's no need to do extractions most of the times. So doing that kind of round tripping, maintaining and keeping the good speed that I transmit with aligners, of course, I have to reduce speed during expansion if I want to proclaim at the same time, because if not, this is not predictable. But of course, it's not the day for me to teach about orthodontics, so only to show what we can do, and what we are getting every single day in my clinic using aligners and be helped by accelerator. You can see here at the beginning and at the end of the treatment with the restorations of that edge, and you can see how we have moved that canine to a perfect line. It's leveled, the gums are not worse, it's a better response of the soft tissues here, and this is the day we remove the attachments. So for sure, after a few months, it will be better, and in that moment, if we want, we can think about grafts, for sure, not before, because if we put a graft here at the beginning, for sure, we will lose it in a few months because we are losing our own tissues. So imagine a graft. The response of the soft tissues is much better, even when we are creating that big round tripping. That, of course, sure, it's dangerous, but it's much better to damage a bit during the treatment with control, giving appropriate forces and using that kind of devices that help us to get better engagement, and at the end, for whole life, preserve the durability of all the tissues, because we have got a good function and a good position of roots. It is here you are the upper jaw. You see how the discrepancy, maybe it's more than 8 to 9 millimeters, and how we project the upper incisors, and for sure the lips will be much better at the end of the treatment. We extract it, we will maintain the midline deviated, and for sure the lips will be worse at the end of a treatment than at the beginning. And today, our ortho treatment planning had to be facial driven. The face had to guide our treatment plan. So we need to take care of that. You see how the inclination of the incisors at the beginning were not correct. At the end of the treatment is parallel, and the bone we have got, even we have to move a lot of the incisors canines, is very good at the end of the treatment. It took only 4 appointments. So imagine, for us it's impressive, because it's not necessary to see the patients every month for sure. Nowadays, today, usually I set appointments with my patients every 2 months. I give them 8 couples of aligners, but if it's a patient like this who is traveling or who is living far away, I can make it better for them, so I can give them 20 couples of aligners, and using Accelerant, as you can see here, the old one, of course, increases our percentage of success. Talking about the consolidation of the movements and the final position of teeth. Here you are, the picture at the end of the treatment, how the smile is absolutely different, and that guy is very, very happy. Another case of severe clotting, you can see how it's very constricted upper and lower arches because they are coordinated, and the main concern of the patient was that crown of that canine that is in position of a lateral incisor. You can see here, I usually do my digital smile architecture that I call, because I mount the models in digital articulator to be sure that the position of the models, upper and lower model, is exactly the same in the face of the patient and in the skull of the patient as it is in the face, in the real face of the patient, and in the clean check. So I do my lines, redistribution of lines, I mount it in the digital articulator. I create my virtual mockup, as you can see here, superimposed in white, exactly in the same position as in the face, not only the pictures. Now, doing that kind of lines with my digital smart architecture, you can find information in the internet. I can tell the technicians even exactly the information I want to get, because of course that instructions about improve the midline. No, improve the midline doesn't work. What we have to do is exactly the amount of movement we need to move the midline. So if I tell the technician that I want to move 1 millimeter, 0.22, it's very accurate. If I tell them that I want to expand that temporary canine 2 millimeters, 77, is the only way to get what I want to get. And I don't allow the technicians to work, because for sure the way they think is absolutely different as I'm doing. Lateral picture, you see that, of course, if I get the expansion I want to get, I'm expecting a leveling of the gums even in premolars, and for sure, after this, the smile will be wider, and we will expose the adequate proportion of crown at the end of a treatment. We can see if at the end of a treatment we don't get exactly the exposure that we want, maybe it's a few parts of a millimeter left, we can do a surgery, but have to be always at the end of a treatment, and always it will be guided by a guide that we will print in our clinic with a 3D printer. This is the STL file at the end of the ortho treatment, and superimposing the mockup, the virtual mockup. You see that it's almost what we were planning, and even you can see here how that crown, that it's a temporary one, obviously at the end of the ortho treatment, we have got a very good leveling of that gums. Remember that gum at the beginning were here, so we have improved a lot, and now I can transfer that information, that image, to my specialists of aesthetic dentistry to create that veneer in that temporary lateral, and improve the edges and change for sure, because here we are gonna put an implant. You see how we have got exactly the response of the soft tissues, helped by the position of and the torque of the premolars and molars for sure, but Accelerant help us to get that situation at the end. It's absolutely predictable. On the other side, almost here you see that if we want perfection of showing that posterior buccal surfaces, we must cut a bit the gum here and that, but it's not cut a bit, Sergio, please, it's cut 1 millimeter 0.01 or 1 millimeter 0.13. So this is precision and this is accuracy. Here you can see the previous picture with that crown. That crown is a very bad crown, that's why the gums are very bad. In that view, you see how the roots are out of bone, so we must give that negative root torque to get that inclination, the adequate inclination to preserve the soft tissues and to allow the gums to creep into the surface we're going to create to level the gums at the end or during the treatment, sorry. Here you are, a video created very fast for you to understand how I do that things to get that, that perfection in soft tissue at the end of the treatment that I will show you later. It takes only a few seconds. Here you can see how we superimpose the mock-up, how we do our measurements, and we can either send the final STL of our setup to the technicians in Invisalign for them to understand exactly the amount of expansion, the amount of inclination, the amount of rotations, or we can use it, that STL, only for us to have a better communication with the rest of specialties, talking about implantologists, periodontologists, and aesthetic dentistry. This is a clean check. You can see here, first clean check, first phase, and the upper side, and here the second one, the second phase. You can see and compare how in the second phase, here the clean check, the gums in that canine that is in position of a lateral, after the first phase, the gums were almost leveled. And remember, it was a lot of degrees of the root out of the bone. So we had to do that negative root torque and to open the space here for the crown of veneer for that lateral incisor. That is the upper jaw, lower jaw with a lot of crowding, very negative torques. I don't have time to show you more clean checks, but you see how constricted is the arch, and for sure, as usual, how the tipping of the roots are very bad. On the other side, you can see that canine and that temporary canine and very consolidated constriction. This is the previous picture, before. During the treatment, I did that. You can read here biologically oriented preparation technique that I do. I remove that crown and I put a temporary composite crown that I remodulate during the treatment every 1.5 months to create a clot and allow the soft tissues and the fibers to consolidate the clot and to get tissue that we will recover for sure during the treatment. You see, after 7 months, how it's improving because we are putting that root into the bone. How it's after 4 more months, how we are creating that clot and we are creating the leveling of that gums. We have redistributed spaces here to and cut that gum here to put a veneer, composite veneer. After 2 more months, you can see how it's consolidated with that temporary crown, and this is a pontic in extension. Here you are, that veneer. This is a composite temporary veneer, but you can see the health of the tissues and how we have got a very good leveling and recovering. It's impressive. After 1 more month, you can see the final situation. Remember that crown, how was? The gum were here. And this is now an implant with the crown, and at the beginning was a temporary canine. You can see how we are getting better support of the tissues, and in that kind of cases in which we have to expand a lot, we expect leveling of the gums. You can see here in premolars as well. We need to do a very good treatment plan. We need to control perfectly the force that we have to apply, the passive attachment to maintain the torque, the intrusion, relative intrusion to get a good curve of SP and good curve of Wilson, and using accelerant, it helps us a lot to get that leveling of the soft tissues that for me now is absolutely mandatory. I cannot do a case if I understand that the soft tissues will not follow the movement of the teeth. You can compare the initial and final situation. It's clear the huge improvement here, especially in that area, but compare the lower arch, compare lateral incisor with canines, compare the leveling here, how we have expanded premolars and molars, We have got for sure a wider smile and much better for the patient. Only 1 year treatment. In 1 year treatment, we can get that beauty, because we are not only for alignment. We have to go ahead and much further, because we need to take care of the health of the patients for life. You can see in that view the biggest step between between incisors and canines. In that view, very constricted premolars. At the end of a treatment, with that response of soft tissues and the leveling of the curve of Spee, upper and lower, you can compare here. It's evident, it's clinical evidence that we are doing every single day. Now, today I can show you a few cases only because I don't have time. But if you come to Spain to my masterclass that is called COIP, Clear Ortho International Program, you will see around 300 cases in all the malocclusions, because within this line, we can treat all the malocclusions, and helped by that kind of forces, soft pulse forces, we get that beauty in the soft tissues as well. That number of cases is enough to believe in my protocols and that it's working with the way we're doing things and our sensitivity of beauty. You can see here how that this is a canine, it's a temporary canine, this is a normal canine with a very bad crown. At the end of the treatment, this is the implant. Look at the tissues, look at the beautiful tissues. We're even recovering. This is ingrowing, this is tissues ingrowing. And the other side, even the tipping, of course, is necessary to be corrected, because if not, either accelerant or nothing will be enough to get a good gum. But look at the end. At the end of the treatment, this is beautiful. And look at the leveling, upper and lower. In the upper jaw, it's very asymmetric, very constricted. That canine with that root out of the bone. At the end of the treatment, with the crown and the implant here, we have got for sure a space for that implant, and we have got symmetry both sides. In the lower arch, with a big lack of space, big discrepancy, you can see how we have got very good contact points, good projection of the roots in premolars and molars to allow the canine guides to be safe. You can see here the X-ray at the beginning with that tipping of the root. If we want to change that tipping to that position without accelerant, maybe we will cause the movement. For sure, the recovery of the soft tissues will not be the same. We have got space enough to put a good implant there who served as a canine guide during the life of the patient. And of course, if we work, we get. And look at the smile of that patient. It's proportional. Look at the exposure of the gums here at the beginning and at the end, how the midline is corrected, how the lips are with a very good support. For sure, she feels much better at the end of the treatment, and it's clear to see in different views. The projection of the lips, everything. Of course, we need scientific evidence, and here you can see a lot of studies and case reports in which we find information about the relation between science and that kind of advices and appliances. But believe me, I haven't read all of them, and I don't do because I believe in, for sure, scientific evidence, but most of the scientifics are not clinicians, and they are not treating real patients most of the times. I've seen in all over the world. I'm traveling every week, and I see how that doctors who are only based in scientific evidence, they are not in the clinic. So they don't see how the tissues are reacting in real patients every single day. And for sure, I am seeing. I have treated more than 7,000 patients, and I know how biomechanics works with aligners perfectly. And for sure, I'm not exclusive Invisalign doctor. I'm orthodontist. I'm treating with braces. But the only limit for me with Invisalign is if the patients can pay that or not. If they cannot pay, I go to option B. That for me is braces for sure. And I love to work with the braces, but it's a 20th century techniques, traditional techniques. And for today, we must offer to our patients what we want to use for ourselves. This is my digitalsmilearchitecture.com. Here you can find my protocols, the trainings I'm giving in all over the world. And here, this is my Clear Ortho International program, in which we are enjoying a lot, giving a lot of promotions every year, talking about our protocols, our way of thinking, and how to get very predictable results using aligners. It's completely different protocols from the common Invisalign technique protocols. Here you are, another case. The main concern of the patient was the veneer he's wearing here in that incisor. In that incisor, I do my lines of digital smile architecture. I superimpose upper arch and frontal view to redistribute the spaces. It's very interesting to send that images to the technicians because they will understand the amount of expansion we want to do, the position of the canines, and we can project. Here we can see how the amount of expansion we have to do between that premolar to that red line, that incisor to that red line, so we can make a capture of the screen and send that picture to the technicians, and they will understand much better the final position we want to get. And for us, it's very easy with Keynote or PowerPoint to do that lines. As usual, I superimpose the models exactly in the same position as in the face it is, because I use digital articulator of Nemo Studio, the mockup, the virtual mockup. You can see how I use the initial STL to get the setup, to move the teeth, and to get the virtual mockup at the end. I superimpose and I send the images to the technicians. Once I have created the final STL with Nemo Studio, then I send to the technicians for them to understand that this is exactly the final position I want to get. So they don't have to work, or they don't have to think. I want that final situation. And for sure, I will receive a clean check with the sequence in which I have to change it. I have to modify a few times to get the appropriate sequence, because in biomechanics, we need anchorage usually. This is only the virtual mockup. So if you show at the beginning the picture and after a few hours after the first appointment, a virtual mockup to the patient, it's another way of selling. It's very important to sell, because we are entrepreneurs as well, not only clinicians for sure. We have to sell to get numbers in our companies. You see how the midlines are deviated, that kind of is up to the line, very big steps between the gums, inclination, tipping. Well, we need to work a lot. This is a class 2. You will see in lateral pictures. We move it that way. We have a maximum anchorage in frontals, but we are distalizing molars. Once we have got a good engagement in molars, the final position, then we start protruding and intruding, leveling the lateral incisors, always at the end of a treatment. The extrusions or the vertical movements have to be delayed till the end of the treatment when we have a good engagement in molars. You see that frontal picture. This is after the few months, after 11 months treatment. So you can compare that situation. Look at that canine, for example, and look at that. Look at the gums, how we are leveling. We work for another phase, and after the 19 more aligners, and it's only 5 months treatment, and the restoration of the incisor for sure, because remember that very bad restoration and the very bad shape, size, and position of that incisors. After the ortho, we put the roots where the roots have to be, and we can restore with composite veneers or whatever you consider. At the end of treatment, we get midline centering, very good symmetry. Exactly what we plan. You can see how we have expanded and maintained the torque using that passive attachments. Here you can see it's a big class 2. In the other side, exactly the same. So we are distalizing. Nowadays, my protocol is changing. So when I have to distalize, I take advantage of the reciprocal movements, so that I'm starting distalizing the second molar, and I'm proclining upper incisors to take advantage of that reaction of the distalization. That will be proclination of the incisors, but with aligners, we will intrude the incisors because we lose anchorage. So today, we have to take advantage of that reciprocal movements using gingival bevel attachments in lingual surface of the upper incisors, and using class 2 elastics 2.5 ounces to maintain the fitting of the aligners. Here you can see the lateral view after treatment, how we have got a beautiful engagement, very good class 1, and a good overbite and leveling of the gums. On the other side, exactly the same, good engagement, class 1, good torque. The upper jaw, very constricted. At the end of the treatment, is appropriate. It's a wider arch, it's a parabolic arch, good contact points, symmetry in torques. That is very important for the health of the tissues. Here you can compare the huge change in soft tissues, and it's for sure helped by accelerant, because we need to change aligners every week. But it's not only the time the most important thing; it's how we get good support of the soft tissues. And you can see how in 16 months, 65 aligners using accelerant, the smile of the patient is beautiful, the kinase is in the correct line, that incisor that wasn't crossed by this completely aligned midline centering. And we have distalized more than 4 millimeters, but we have maintained the profile, at least maintained, because we have proclined incisors and we have give support to the lips. For sure, it's a good result. And the smile, this is not the mock-up, the virtual mock-up. This is the real situation, and you can see that it's exactly what we was expecting. Let me show you that case. It's a huge case of 13 millimeters overjet with incompetent lips, bimaxillary cos class 2. You can see here the bad healthy tissues, leveling and level cant, midline centering. After the treatment, we got very good midline centering, good projection of the you can see here the premolars. Of course, we find abstractions and we have lost tissue. Of course, look at the Wilson curve. We have to get that projection of the premolars and put the roots into the bone and get a completely flat curve of Spain to get that result. Because look at that big step between central incisors and that premolars. It cannot work ever. It's a very young girl. So if we don't fix it, that teeth will be lost after 13 or 15 years for sure, because the bone will be resorbed. Compare that situation of the SPE with this one. How we have got perfect cuff of the SPE, upper and lower, and we allow the mandible in that way to be anterior-rotated during the treatment to be at the end in a very good profile. This is at the beginning how it's almost a surgical case. It's 13 millimeters overjet. But if we use properly forces using class 2 elastics and we use accelerant to improve the stimulation of the ligaments in the TMJ, and the glenoid cavity is going to remodel it properly to anterior-rotate the mandible and to get a consolidated class 1, skeletal class 1. You can see here the huge overjet at the beginning. Look, it's huge, it's 13 millimeters overjet. So I do that, I expand, they rotate upper molars, distalize upper molars a bit, and retrude upper incisors to get a better support of the lips. And of course, in the moment I have completely flat the curve of the SPE, then I'm starting using class 2 elastics, 4.5 ounces, 1/8 diameter. And after 2 months, once the ligaments of the TMJ are used to that forces, we start using 6 ounces, class 2 elastics, 22 hours a day. So this is the overjet in the left side. This is after the ortho treatment. You can see how we have reduced absolutely. We have got a very good class 1 in less than 1 year treatment. That's the other image. You can see how we have to intrude with expansion. We are creating a proclination for sure of the premolars and molars, and we are intruding relatively. We have to intrude a bit more that molar because it's inclined. The tipping is very bad because it was destroyed. So we have to open more the distal cusp to restore at the end of the treatment. Here you see the clean check, how we can protrude, incline, procline, and intrude incisors using that beveled attachments in molars, because if not, we will misfit the aligners. You can see here the round tipping we have to do to create that good tipping of roots. I had to do a second phase of 16 aligners because during the second phase of the round tripping, I lost curve of SPE. So I had to intrude again during 16 aligners, incisors and kinases to allow the mandible to anti-rotate and to allow the class 2 elastics to get the class 1. Here, you can see the initial picture, left picture, how we intrude the molar, how we create that very good curve of SPE and good engagement. You can see here the aligners with elastics. In the other side, with that tipping of the roots, how we got it, and of course we have to restore the cusp of molars as well. But look at how we have closed the overjet and we have maintained a very good overbite. With elastics, you can see here with the aligners, the lower arch is very bad. You can see how we have changed the proclination and the torques. For sure, at the end of the treatment, the profile is very good. very good projection of lips. You can compare at the end of a treatment the sensual smile and the lips of the patient. Here you have the X-ray at the beginning with a big curve of SPE. At the end of a treatment, it's completely flat. We have intruded the incisors. If you want to see the lateral X-ray with that position of the lips and that big retrusive mandible, at the end of a treatment, we have remodulated the glenoid cavity, and it's an adult. We're doing every day that kind of cases because almost 40% of my cases are class 2. I know how to manage it. Compare that lips, compare the reduction of the object and the class 1 for sure. Even here at the beginning, the patient is trying to close with a lot of force, and at the end, it's a very soft close. Let me show you a video for you to see how the experience of the patient was incredible, but what is most important, she understands
Pues empecé el tratamiento porque mi hermana también lo había hecho y veía los resultados en ella y me motivó. Había llevado también ortodoncia cuando era más pequeñita y pues como después del tratamiento no tuve retenedores, se me volvieron a mover todos los dientes y ahora con Invisalign me parece que ha sido súper fácil.
The projection of the mandible. At the end of the video, I will tell the patient to move the head and bite. A very good class 1. Few more seconds.
La sonrisa me ha cambiado muchísimo, también un poco la forma de la cara que como que se me ha abierto un poco más abajo, pero estoy encantada. En general estoy encantada con el tratamiento.
Cierra la boca, ¿eh? Ahora sí. Y gira un poquito la cabeza. Y ahora para el otro lado. Estupendo. Bueno, muchas gracias.
Well, you can see how the patient was very consolidated class 1. She's very happy. She's not feeling pain in the neck. She's not feeling headache anymore because we have placed a mandible in a very good position and it's consolidated. And to finish, I will show a complete pack. This is a patient who was living very far away in Saudi Arabia, in Jeddah, and he wanted me to treat her, to treat him, sorry, in Spain, in Madrid. So he came in that situation with that very big crowding. You can see how that incisor is there in the middle of nobody, it's absolutely lost in the middle of the palate. The amount of expansion we want to create to get that projection of the crowns in premolars and molars and get the space for that incisor and this one. You can see that we have to move almost 9 millimeters, that incisor that is already proclined. This is crazy. This is crazy. We are doing with aligners I can press exactly here, closer to the center of resistance to apply forces of buccal root torque, same time that I'm protruding the incisor and using gingival double attachment in buccal surface of that lateral incisor and using accelerant, it creates the support enough, the bone remodeling is very good to get at the end a good result. And for sure, I'm very accurate. I give exactly information I want to expand, I want to rotate, I want to distalize. You can see we can make millions of measurements. Here you are, the midline deviation. Here is the central incisor. The lateral incisor is there inside. You cannot see, of course, because it's in second row. Very constricted. The canting of the plane, very bad canting of the plane. If I tell the patient open the mouth, I can promise you that it's human. It's a human. Look at that canting. Look at that unleveled incisors. That incisor there in crossbite. I have to intrude molar and premolar as well to allow the implant to have a very good crown at the end of the treatment. That side we cannot see the lateral because it's out of the line of the arch. You can see here how the lateral is. When I see the picture, I can't believe it, but we have to believe if we see. If I see, I have to believe, and we're doing. If you come to my clinic, I told you before that in my masterclass I'm showing more than 300 cases. You can, during the masterclass, you can select 10 patients with whatever you want and see that patients after 1 year and after 2 years treatment, and be sure that what we are showing, it's what we are getting. It's absolutely amazing what we are getting using proper sequence of aligners, proper selection of attachments, and using accelerant. This is the lower arch in which I have to create a good arch shape. It's very bad bone shape. I have to protrude incisors and create good symmetry. Very much more constricted one side than the other. That is the clean check I did in a patient who was living far away, a few thousands of kilometers from Madrid. So I saw the patient 5 times or 6 times. Look, I want to do that round tripping, of course, because it's not possible to get that much space that I have to get. Using that gingival double attachments and applying the forces properly, giving the adequate sequential information of buccal root torque, it's we expect to have good results. You see the initial picture after the ortho treatment. So compare from this to this with the bad shape of the incisor. Of course, with ortho treatments we cannot change the shape of the incisors, but you can see here that the incisor was 9 millimeters back to that position. And look at the gums. Seems to be not bad at all. Of course, at the end, the treatment, during that phase, the second phase of the treatment, I do composite veneers, but temporary, that I remodulate using biologically oriented preparation technique to get that adequate shape, because the gums will be where the surface of the teeth are. So if we want perfect gums, we need to get perfect surfaces, buccal surfaces. This is absolutely mandatory. I love to do that, and today I do with all my cases. This is after the treatment. Compare. This is an incisor who was 9 millimeters back. Look at the gums. It's not bad tipping, it's not bad torque. The gums are perfect all over. You can compare that situation with that incisor who was 9 millimeters there, and this one was almost 6. So look at the inclination of the incisors, the very good torques with that temporary composite restorations. At the end of a treatment, we will put, whenever we consider Zafiro or other porcelain materials, to get beautiful image, but we have got beautiful tissues, beautiful midline, recovery of tissues, and the patient, of course, is absolutely surprised. Look at that image. After the treatment, we have jumped that bite. You can see. Then we have to work another second phase with Invisalign, and at the end, doing that biologically oriented preparation technique. You can see that huge movement we have to get. Look, compare with that separate. It's impressive, the amount of movement and the amount of space we create only doing that. Less IPR is almost nothing, but the expansion and the round tripping allows us to do that from this to that. It's absolutely crazy. Of course, without Accelerant, I don't try to do that kind of treatments. I have to plan other things, but my patients are understanding the value of that, the value of a good treatment plan, the value of that kind of devices in our century. You can compare the STL at the beginning with my mock-up, and at the end of a treatment with the final mock-up. So it's exactly, look at that incisor. This is STL from iTero scanner. Look, that incisor, and at the end of a treatment, how it is. Impressive torque of the incisor that we have moved 9 millimeters. Even the lower arch, that is very important. We do that movement. We start moving only that premolar, then this one, and when we get good symmetry, we start expanding both sides and intruding incisors, leveling the canting of the plane. We need to manage properly the biomechanics to see that results from that situation to this one. Compare the amount of bone we are creating with that expansion. Look at that bone. Look at that no bone, and here we have created a big bone to maintain consolidation of that projection of that incisors, and we have changed the shape of the bone. We change, we remodulate. We have to believe in that if we are getting every day. The ortho is changing in the last 5 years, is changing absolutely to a better way. You can see the bad X-ray at the beginning, but the most important one is at the end of a treatment, in which you can see that incisor who were 9 millimeters back, this one almost 6 millimeters, and the amount of intrusion of the lower incisors we have created, that the curve of SP was very high and very asymmetric. At the end of the treatment is completely leveled, and the roots and the level of the bone is impressive and maintained. This is previous picture after the ortho treatment and at the end of the treatment with the composite restoration, but temporary composite. This is not definitive, it's not finished. But look at the impressive result at the end of the treatment. So thank you so much. It's a huge pleasure for me to share with you, colleagues, and I hope to see you there in the US, or if you come to Europe, I'll be so pleased to be by your side. If you want to contact me here in the Instagram at Ivan Malagon, or Facebook, you can find me. Even if you want to send me any email, I will try to respond your doubts. Now I can see that I have some questions to answer. I don't have a lot of time. I will try to answer a few of them. Let me read it. Yeah, the first one is, could you please tell us about your experience with Acceleron in periodontal patients? Are there any considerations we should know regarding this group? Well, of course, orthodontic treatment in periodontal patients is recommended as long as the periodontal disease is controlled and inactive. We all know what are the causes of the loss of support, and one of the main causes is the overload of these tissues due to inability of the periodontal ligaments to absorb the charges that it receives during function if teeth are not correctly aligned and engage with their antagonists. So we have to get this, of course. The use of Acceleron in that kind of patients even improves the result as long as the technique followed by the orthodontics and the magnitude of the movement and the force he should transmit are adequate. I usually change aligners every 10 days in severe periodontal patients. The next question is, could you please tell us how are you offering Acceleron to your patients? Offering, I understand how, well, I usually offer Acceleron to every single patient, but I found that in around 30% of my cases that are cases above the limits, it's absolutely necessary the use of that device to have the warranty of a good reaction of periodontal tissues. I'm used to offer a fixed price for my ortho treatments and usually include Acceleron. If I get better predictability and more consolidated position of teeth, it's worth it for me and for my patients, of course. One more question. In the case of the last woman, have you done sequential distalization or do you only combine Acceleron with elastics? Well, diagnosis is the key, always. Diagnosis is the key. If the cause of the class 2 is combined by maxillary and I want to retrude a bit the upper incisors to get better lip support, I have to expand, derotate, and distalize upper molars to get a wider arch, as well as to allow the mandible to anterorotate and retrude incisors. In lower arch, I must get a completely flat curve of span by intrusion and proclination of lower incisors and canines, and start using class 2 elastics 4 ounces and a half to allow the remodulation of hard tissues in glenoid cavity and anterorotate the mandible to a skeletal class 1. Well, one more, because it's 1 millimeter remain. What's your aligner changing protocol with Acceleron? Are you changing every 7 days or are you lowering that to 4 or 5? Well, I usually change aligners every 7 days, yes. In some cases in which the patient's compliance is good, using Acceleron allows me to change them every 5 days. I select some patients and I can change aligners every 5 days some of times. So that's all, doctors. Thank you so much. I hope you have have been above your expectations and you have enjoyed a bit with me in that Friday that from now we have to rest a bit. Thank you so much, doctors. Bye-bye.